And also, I would like to thank to Sanofi also to sponsoring this meeting. And Aro is a Mediterranean society, but you will ask maybe why Switzerland is in the Mediterranean area. In our society we also accept members from origin. So I'm from Turkish origin, so Turkey is in the Mediterranean area. That's why I am a member of the Aro. So we can maybe consider also Kiwi also from Mediterranean area, because we have the river going down to the Black Sea, and Black Sea goes to the Mediterranean. So this is our hospital in Lausanne. For those who are interested, this is like my email address and my telephone numbers work. So when you treat head and neck cancer, historically, when you put all the stages in the same place, then you have a quite high local failure risk, between 25 to 60%, and again a quite distant failure risk. And the 5-year overall survival, if you do only surgery in locally advanced case, it shouldn't be more than 30 to 40%. So the first evidence of doing post-operative or preoperative radiotherapy goes from multiple papers from 70, 79, and in 91 there was a randomized comparison between preoperative and post-operative radiotherapy, and where we saw that the higher dose of radiotherapy was good for high-risk patients, and the post-operative radiotherapy was better than preoperative radiotherapy. So there are different risk groups in head and neck cancer: low-risk patients, intermediate-risk patients, and high-risk patients, according to different series. And these risk factors were detailed first by Lester Peters, the publication in the Red Journal in '93. So the low-risk patients, they don't need post-operative radiotherapy. The high-risk patients, they have extracapsular extension or 2 or more adverse features, and they need doses at least 60 gray. And the intermediate risk, you can control them with some lower dose of post-operative radiotherapy, like 50 gray or something. So what post-operative treatment for high-risk patients? So high-risk patients with resectable disease benefit more adjuvant chemotherapy, but when you put adjuvant chemotherapy, you see less nodal failures and maybe less distant metastasis after a RTOG study published in '91 by Laramore. But however, you don't have an amelioration of the local control. So the rationale of chemoradiation, so make a combined chemotherapy and radiotherapy, is to overcome the radioresistance, to increase the local control, and eradicate systemic micrometastasis. So for this reason, 2 important post-operative radiochemotherapy trials were done in the world. One was the RTOG, the American study, the intergroup RTOG study, and the other one, the European URTC trial, 22931. So the criteria of inclusion of the patients, or exclusion criteria, for the URTC trial was used the Lester Peters criteria, and for the RTOG trial, that was the RTOG Laramore trial, where 2 or more lymph nodes, extracapsular expressed, or positive surgical margins. In the URTC study, we had all these parameters, but more vascular embolism, perineural disease, positive surgical margins, etc. So the URTC study was activated in '94, and it was closed in 2000. And it was published in 2004 in New England Journal of Medicine. And in the same issue, we had the RTOG study and the URTC study, both of them published. So the eligibility criteria, as I told you, there was histology confirmed squamous cell carcinoma, primary surgery with curative intent, oral cavity, oropharyngeal, hypopharyngeal, laryngeal cancer. So all these details, no distant metastasis, etc. So the randomization was very simple. Postoperative radiotherapy of 66 grade versus postoperative radiotherapy of 67 radiotherapy plus 3 cycles of platinum. And the primary endpoint was disease-free survival, and the secondary endpoints were overall survival, etc. So we were the second center in this trial putting patients. And there was no unbalance for age, sex, end-stage tumor differentiation, resection margins, or extracapsular extension in the both arm of the study. This is the postoperative radiotherapy alone, and this is the postoperative radiotherapy plus chemotherapy arm. And here you see the distribution of the different sites according to the arms. The light blue is the radiotherapy, and the dark blue is the radiotherapy plus chemotherapy. This is the distribution according to the surgical margins, positive and negative in both arms. They are equally distributed. Again, the number of involved nodes, 0, 1, or 2 or more, equally distributed in the two arms of the study. The extranodal spread was a little bit higher in the chemotherapy arm, as you see here. And the time interval between surgery and radiotherapy, which is an important factor in terms of local control, was also equally distributed in the two arms of the study. And if you look to the radiotherapy dose distribution, there was on schedule in arm 1, 73% of the patients, and in arm 2, 75% of the patients. And as you see here, there was only 5 patients who received less than 50 grade. However, when you look to the chemotherapy compliance, because there were 3 cycles of 100 milligram per meter square of chemotherapy cisplatin in this trial, only 50% of the patients could receive their third cycle, about more than 60% their second cycle, and 90% their first cycle of chemotherapy. So if you look to the results, the study concluded with, for the primary endpoint, which was progression-free survival, a better survival for the combined therapy compared to radiotherapy alone, postoperative radiotherapy alone, with a significant p-value. And the overall survival, which was a secondary endpoint, was also significantly higher for the combined treatment. The p-values here, as you see. And the cumulative incidence of locoregional relapses was higher in the postoperative radiotherapy arm compared to the combined therapy arm. And when we compare the cumulative incidence of late adverse effects, grade 3 or more, there were no difference of incidence of late effects between the two arms of the study. So this was the European study. Now let's present the American study, which was published in the same issue of the journal. And again, as you see, there is the same randomization, radiotherapy, postoperative radiotherapy versus radiochemotherapy. The inclusion criteria are a little bit different from the URTC study, but we will come to this later. And when you look to the primary endpoint of this study, which was locoregional control rate, the other study was disease progression-free survival. This study's primary endpoint was locoregional control rate. It was significantly higher for the combined therapy arm. When you look to the disease-free survival or progression-free survival, the combined treatment was better, significantly better than the postoperative radiotherapy alone, with a significant p-value. However, the overall survival p-value was not significant between the combined therapy, say, postoperative radiotherapy plus chemotherapy versus radiotherapy. And when you look to the toxicity in the RTOG study, the late effects were, or let's say the total side effects, grade 3 side effects, was significantly higher in the combined treatment arm compared to postoperative radiotherapy alone. So why we had these small differences between the European study and the American study? So to do that, we did a meta-analysis putting the URTC and the RTOG data together, and we published this in the Head and Neck in October 2005. So this is the distribution of the URTC versus RTOG eligibility criteria. So the common criteria are here: positive margins and extracapsular extension. The RTOG different from the European study, 2 or more positive nodes. And the European criteria different from the American criteria: stage 3-4 disease, level 4 or 5 lymph nodes, perineural disease, or vascular embolisms. So let's look in detail what happens when you do the analysis according to this. So these also shows a little bit the difference between the URTC and the RTOG studies. As you see in the URTC, you have a little bit more hypopharyngeal cancer. Oropharyngeal cancer was higher in the American study. The end classification, there is, let's say, more and less, let's say more and 0 and 1 patients in the European study compared to the American study. And the American study, the majority of the patients, or nearly all of the patients, were N2 and 3 disease. So, according to the primary endpoints, both studies were positive. So, a significant p-value for the progression-free survival, significant p-value for local and regional control in the American study, which were the primary endpoints. When you look for the overall survival, significant p-value for the European study, no significant value for the American study. So, if you look to the, when you combine the two studies, then you obtain a significant p-value for local regional control in all patients. Of course, it was significant in URTC, it was significant in RTOG. When you put all the 750 patients, then you have, again, a significant p-value. However, when you analyze these patients separately in terms of the circles, if you look to the intersection of the circle, then you have significant for all situations. However, if you look to the left side and the right side of the circles, which were the European criteria which was not used in the American study, or the American criteria which was not used in the European study, then you don't have any significant p-value, neither in the URTC nor in the RTOG, nor when you combine both studies. When you look to the disease-free survival, then you see that it's significant in both studies, and when you combine the 750 patients, again, it's significant for both. And when you separately analyze the circles, the intersection was significant for all, but separately and both, and the p-value was not significant when you look to the left and right side of the circles. So if you look to the overall survival in all patients, then you know that I showed again before, the URTC study was significant for the overall survival. The RTOG study was not significant for the overall survival. However, when you combine the two groups, let's say when you analyze the 750 patients, you obtain a significant p-value for the totality of the group. Again, if you look the overall survival according to the URTC RTOG, so the RTOG was not significant for the patients eligible for both studies. This is the intersection of the two circles. However, it is significant for both. And when you look for the overall survival for patients eligible for only one study, left or right side of the circles, not significant, not significant, and not significant for both. So, this is the overall survival for patients with positive margins and or extracapsular extension, so which is the intersection of the two circles. P-value 0.02 for the URTC, 0.06 for RTOG. When you look to the overall survival for patients without positive margins and extracapsular extension, so this is the left and right side of the circles, then you have insignificant p-values for both studies. So then the conclusion, according to this meta-analysis, the impact of chemotherapy added to postoperative radiotherapy. Please, I mean, this discussion is not discussing the validity of the postoperative radiotherapy. We are not discussing postoperative radiotherapy is indicated for all these situations. But the question is, when you have to add chemotherapy, so it is obvious that when you have a patient with positive margin or extracapsular extension, then definitively you have an indication for postoperative radiochemotherapy. You have to add cisplatin to your treatment. If you have those criteria, like perineural disease, vascular embolisms, etc., then probably also it is indicated. However, for patients without all these criteria, but just who has 2 or more lymph nodes, probably the influence of chemotherapy is not so indicated. However, you have 2 randomized studies with positive p-value. So if you do the postoperative radiochemotherapy, this is of course level 1 evidence, so nobody can criticize you. But this is just the in-deep analysis of those 2 studies. So are there other meta-analysis? There is another one published in 2007 in Head and Neck by people from Canada. And here they put not only the URTC and the RTOG study, but also 2 more single-center trials, old trials. One Hungarian trial in 2003 published in the Red Journal, and a French trial published in 96 in the Red Journal. So this is the distribution of the patients. As you see, these are the Hungarian study and the French study are small studies. So when you combine all these 4 studies, you have a significant p-value for the local regional control, as you see here. The combined treatment is favored in all. And when you look to the overall survival, again, when you combine these 4 studies, you have a highly significant p-value favoring combined modality treatment in postoperative setting. So, what is the current status of adjuvant treatment? So I put this data just showing that we can also, we were interested in the past, before the chemotherapy era, to do accelerated postoperative radiotherapy, which has been shown in randomized studies that accelerated radiotherapy was better than the standard radiotherapy, standard fractionated radiotherapy. Of course, when you don't put chemotherapy in it. There was a phase 3 Italian study, phase 3 Polish study, and phase 3 Egyptian study. All those studies were positive in terms of significant p-value. They were published in the years 2005 and 2002. And the postoperative radiotherapy plus chemotherapy is better than the postoperative radiotherapy, as you see here, all these data that I show you. So maybe in the future we should look for the accelerated radiotherapy plus chemotherapy. Is it better than the accelerated postoperative radiotherapy? But the acceleration of treatment in head and neck cancer lost its, let's say, mode during these days, so it is not done anymore like in the past. The value of Erbitux, the anti-EGFR treatment, we don't know yet in the postoperative setting. You know the drug panitumumab, which is a antibody, totally humanized anti-EGFR antibody of the Amgen. We were planning to do a URTC phase 3 study on it, but in the last moment, a couple of months ago, it was cancelled, and Amgen doesn't want to do. We were going to start the study. We passed ethical committees everywhere in Europe. This was a very important study of 800 patients combining postoperative radiochemotherapy with or without panitumumab, which is the commercial name is Vectibix, probably you know it, but the study is cancelled now. RTOG during this time did a phase 2 randomized trial having 2 arms. One is Erbitux plus platin and the other arm Erbitux plus docetaxel. But this study finished, and probably the RTOG will continue the phase 3 study on this subject. So what is the take-home message from my talk? We can say that there were The differences in eligibility criteria in both studies, in European and American studies, can explain the difference in the outcome in the trials. Don't forget, in the American study, the majority, 94% of the patients had 2 or more lymph nodes. They were N2 and N3 disease. In the European study, N2 and N3 disease was about 50%. So probably, when you put chemotherapy concomitantly with radiotherapy, you are increasing mostly the local regional control, and you're increasing the survival by doing this, not by killing the distant metastases. I will come to this issue, the value of induction chemotherapy, etc., in my other talk. So we can definitely say a level 1 evidence that postoperative radiochemotherapy is definitely superior to postoperative radiotherapy alone in locally advanced head and neck cancer. And the comparative analysis of URTC and RTOG trials support the routine administration of combined radiochemotherapy in patients with positive margins and or extracapsular extension. And for patients without positive margins and extracapsular extension, if you do postoperative chemotherapy, you are on the level 1 evidence according to the meta-analysis if you put all these data. However, in this direction, you can imagine new studies like using only anti-EGFR treatment or accelerated radiotherapy, etc. You have a little bit more questions in this place. So thank you very much for your attention.